Okay. Good morning. How is everybody? Only 1 week left. 2 classes after today. Goes quick. So between Monday and today, you guys had chapter 7 in your book. So reading chapter 7 in the yellow book and then taking the test on page 187 in the spiral book. Let me go ahead and get your scores. Brianna, Natalie. Oops, I'm sorry. That would explain. Let's try that again. Oh. Emily, Michaela, Tiana, Mia, Autumn, Yenison, Ashley. Ashley, do you have 5 and 6 for me?
5 and 6?
Yes.
Yeah, I think I forgot my book, but I think they were 100.
Okay. Thank you. Eliza, Ariani, Christina, Madison, Ashanti. Thank you. Any questions? Any questions? All right. Over this weekend, you have 2 chapters. You have 8 and 9. 8 is on nutrition. It's not a long chapter, but it is a pretty heavy chapter because you do need to understand different diets and how what we eat really does affect our overall health. So if a patient has a low sodium diet, we need to make sure that we're giving them the right tray, because if we don't, if we give them just a regular tray and it has a lot of sodium, there's going to be health consequences to that for them. So I think there's 8 diets that you have to learn. It's not overly hard or complex. You just may want to make some flashcards. Like I said, it's a short chapter, but pretty intense. Chapter 9 is on rehabilitation, and it's going to go over different positions. You do need to know those, the difference between supine and prone, lateral, Fowlers, and Sims. You need to know those positions. So again, flashcards are going to be your helper there. Okay. All right. This is our final review. This is it. There will not be a review on Monday. So if you don't remember anything that I'm about to say, if it's not sparking some little neurons in your brain, then you're probably going to want to go back and review, because this will be the very last review that we do. Okay. We, as a CNA, our job is to follow the care plan, period. If you can't follow the care plan, you let the nurse know. We're not going to change that care plan in any way. Don't add to it. Don't take away from it. Don't let your brain go, well, if, maybe, what if. None of that applies. The care plan stands alone. Don't add or take away. And as we're doing the skills that are on the care plan, we should be making observations and reporting those to the nurse. Okay. Every skill starts with an opening. Doesn't matter what it is. And this actually came up in one of the Facebook groups that I'm in. Do we actually have to do the whole knocking and introducing ourselves for every single skill? And the answer is yes. Every skill starts with an opening. If you were just in the patient's room 3 minutes ago and you left and you had to come back, you should still do the opening, period. Just because you remember the patient doesn't mean the patient is going to remember you. You have to think about all the people that go in and out of that room every day. You're nothing special, right? You're dressed the same as everybody else. So they're medicated, they're self-absorbed, they got a lot going on, they're concerned about their health. They're probably not going to know you from the nurse, from the housekeeper, from the dietary aide. You're all going to blend in together. Does that make sense? So every time you walk in that room, you should knock, identify your patient, identify yourself, and let them know why you're there. That's non-negotiable. So the answer to the question on Facebook is yes, you have to do the opening every skill that you're asked to do for the exam. Good? Makes sense? So your opening starts with a knock. You're going to greet the resident because we are nice. If nothing else, we are always nice. We're going to identify our patient by name. We're going to introduce ourselves by name and title. We'll describe what we're there to do. We're going to get permission, and then we can close the curtain. Once you close the curtain, you've got to go wash your hands because germs. Once you wash your hands, you can go get your clean supplies. Don't get the supplies before you do the opening. When you're getting supplies, you have to consider whether you need gloves. We're going to use gloves if we're touching body fluids, personal skin, or non-intact skin. If you do wear gloves, the first thing they should touch is the patient, not the supplies, not the environment, the patient. So wait to put your gloves on until right before you start the skill. Once you have touched the patient, though, be careful about what you're touching in the environment. We don't want to cross-contaminate. And then remove those soiled gloves correctly by pulling up at the cuff and then going under on the second one. If you are going to use supplies, you're probably going to need a barrier because we have to have a clean place to put those clean supplies. Now, you can only get your supplies with clean hands. Please remember that. But go get the barrier first and then put that on the table, then go get the rest of your supplies. That way you don't hold any supplies up against your uniform accidentally. One of the supplies you may need to get is a privacy blanket. Privacy blankets are used anytime the patient's uncovered or undressed. They're there to keep the patient warm and provide privacy. They have two uses. When you're putting it on, don't snap it or shake it. Lay it out over the sheet, pull the sheet down underneath. And then at the end of the skill, wait until you've removed your gloves before you remove the blanket. That keeps you from touching that sheet that's going to go right up next to their face with soiled gloves. Anytime we use linens, linens are sheets, clothing, towels, washcloth, anything from here, privacy blanket, any extra pillows. These are all considered linens. And if you're going to touch linens, there's some rules we have to follow. Linens can't touch your uniform. You have to have clean hands to get your linens. Don't snap or shake the linens. Anything you take and don't use has to be discarded. And then if we're going to put anything under the patient, clean rolls toward us, dirty rolls away. That's the rule that we follow. Nothing touches the floor ever. Not clean, not dirty, nothing touches the floor. If your patient is in bed, they have to stay safe while they're in bed. So that means they got to be in the middle of the bed at all times. If the patient is rolling themselves, they'll shift. So they're in the middle of the bed. But if we are rolling the patient, we're going to scoot them toward us first and then roll them on their side so that after the roll, they're in the middle of the bed. Remember, that's our checkpoint we're trying to meet. Keep the patient from being close to the edge of the bed. Okay? Keep the patient safe. When you're turning a patient, always turn a patient away from you. You remain behind, they're behind. Never roll a patient toward you. If they start to roll backwards, you can't stop them. You're in the wrong position. But also, you never want somebody eye level with your crotch. If we're going to wash anything, we have a lot of washing rules. There's some rules that we have to adhere to here. Don't put soap in the basin. When you get water, use a paper towel to turn the faucet on. Check the water. It should feel warm. Not hot, not cold, and then ask your patient to check it as well. Whatever we wash, we rinse. Whatever we rinse, we dry. And if we're going to wash a wet body opening, we use that leaves method that we learned last class. We're going to see that again today. Don't let your water get cold or soapy. If you're going to use lotion, warm it up first and wipe off the excess. Those are our washing rules. Basin cleaning, anytime you use anything to hold any liquid, a cup, a basin, a graduate container, anything that holds liquid needs to be cleaned before we put it away. Now, you're going to dump that liquid wherever it would normally go. If it's water, it goes in the sink. If it's body waste, it probably goes in the toilet. If it's saliva, it'll go in the sink because that's where we brush our teeth. So dump it where it normally goes. Then rinse your basin, dump that where you put the stuff, whatever the fluid was. So if you're working with body waste, you rinse the container and put the rinse water in the toilet. If you're working with saliva, you rinse a container and dump the rinse water in the sink. Wherever the stuff went is where your rinse water goes. And then you can dry it and put it away. For the test, that's all they require is rinse, dry, store. But in a clinical setting, you're probably going to have to disinfect now and then. And remember that you cannot hold a basin with dirty gloves or dirty hands if you're disinfecting it. You have to set it down to disinfect. Okay? Good. We also learned shoe rules. We learned this last class. Remember that slipper socks are not enough. They don't protect against sharp objects. They don't really protect against slips and falls. And they certainly don't protect against pathogen transfer. So if your patient is out of bed, they really should have shoes on. Okay. So if their feet hit the floor, we got to think about their shoes. Now, if the patient doesn't have shoes, that's a good nursing problem. Take that to the nurse. Hey, I'm trying to walk Henry. He doesn't have any shoes. I looked everywhere in the room. He doesn't have any. Let the nurse know, because the nurses can call the family. They can call the facility the patient came from. If the patient doesn't have resources to get shoes, they can call a social worker. We've got some resources to work with. Remember, healthcare is a team sport. Anybody here watch sports of any kind? Anybody watch sports? Okay. Can you imagine? Let's just pick on football today. Can you, or let's just do hockey. Hockey's big in the news right now because of the Olympics. Can you imagine just one person on the hockey rink against the whole team? Is that going to work out for anybody? No, you need the team. You need somebody guarding the goal. You need somebody who is, a great shot shooter, can get the puck into the opposing goal. You need defend. You need a whole team of people. Everybody has their own strengths. Everybody has weaknesses, but the team works together. Well, we have to think of healthcare like a team. If you think you're the only one on the rink, yeah, it's not going to work out so well. So if the patient doesn't have shoes, let the nurse know, because we can solve that problem. Good. Use your team. All right. If we're going to walk a patient, a lot of times you'll have a care plan that says to use a gait belt. Gait belt is a flat canvas belt, goes around the waist. When you put it on, you want to make sure it's snug enough to stay put. The way that we check that is we tighten it so that we can only fit 4 fingers flat between the belt and the patient. That means that it's tight enough, it's not going to slip up as we use it to lift the patient. So 4 fingers. Before you lift a patient to a standing position, their feet should be flat on the floor. And before you stand them up, you've got to count to 3 to make them a partner. Don't just grab somebody and pull them up. If they're not ready for it, their equilibrium will be off and they're going to be likely to fall. Once you get them standing, ask if they're dizzy before you walk. That's very important. Don't wait until you're way over there to finally say, hey, you feeling okay? Because if they say no, you don't have an exit strategy. So ask while you're standing. Are you okay? Feel okay? Feel like walking? Everything good? And if they say yes, then you can walk. If they say no, you're going to sit them down and go find a nurse. While you're walking them, also keep an eye on them. Check in with them. How you feeling? Everything okay? If they get a little woozy, a little wobbly, a little funky, then get them sitting on the floor so they don't fall. Don't try to rush them back to the chair. They're not going to make it. Okay? If you're going to help somebody sit, make sure that chair is behind their legs and they can feel it. And then lower them using the gait belt with a controlled lower, making sure after you sit them down that they're positioned in the chair properly. Their hips are against the back of the chair. Just make sure they're seated properly and that they're not going to fall. Make sure you're using the right body mechanics so you don't throw your back out. And then the closing is done at the end of every skill. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Your bed is in the low position. Your environment is clean. Would you like a magazine before I go? Here's your call light. Open the curtain. Go wash my hands. After I wash my hands, then I'll document if I need to. Remember, there's 4 documentation skills. You will get 1. So far, we've learned pulse and respirations. Today, we're going to learn feeding. And Monday, we're going to learn drainage bag. So there are 4 documentation skills. You are going to get one of those skills. You will. So pulse, respirations, feeding, and drainage bag. You will get one of those. So after you wash your hands, you document, and then you wash your hands again. We learned how to take a pulse. Pulse is a measurement of how many times a heart beats over 1 minute. You use your fingers, not your thumb. Pulse is located at the very top of the thumb side of the wrist at the bendy part. Normal is between 60 and 100. And for the state exam, our care plan tells us to count for 1 full minute. So that's how long we're going to count. Hopefully you'll get some number between 60 and 100 when you're counting. If not, you let the nurse know this is an abnormal number. This is a documentation skill. Make sure you document at the end. We learned how to dress a resident with a weak arm. If the patient has 2 healthy arms, they can have a pullover. You know, they can stretch their arms out. There's nothing wrong with those arms. They can move around. But if the patient has a weak arm, we dress them from side to side. That way, that weaker arm doesn't have to do a whole lot of movement. We make the stronger arm do the movement. So we undress strong arm first and dress weak arm first. Gather your clothes before you get the patient undressed. Make sure you've provided privacy for the patient. And put on whatever the care plan tells you to. So in this case, it's socks, pants, shirt. Don't overextend or force movement. Make sure that you're providing support as you're moving that weaker side.
If you have a patient with a weaker arm that doesn't have a button up and all they have is a pullover, would we then just kind of go over the weak side and like try to get their head in?
Yes, it's arm, head, arm. Yeah, if you're using a pullover. And honestly, if you're using a pullover, it really should be 2, maybe 3 sizes bigger than what they would normally wear. Okay, that way you have the give to it. But let the nurse know. If you're dressing somebody, they don't have a button or snap front, anything, let the nurse know. Because again, that's a problem we can solve. Okay. All right, hand and nail care. This is a mini-manny. Soak the hand, wash the hand, rinse the hand, dry the hand, clean under the nails, wiping it off in between nails because you don't want to import dirt. File in one direction only, put some lotion on and wipe the lotion off. That's hand and nail care. You're doing this to keep the nails manageable rather than letting them grow, and then cut. If you file them once or twice a week, they never grow too long. They never have to be cut. Making an occupied bed. This is changing the bed with a patient in it. And you change the bottom sheet a half at a time using that clean rolls toward me, dirty rolls away. Then put the top sheet on, get the corners under the mattress, change the pillowcase. Side lying position, my favorite skill. You're going to turn a patient over so they're in the middle of the bed after the roll. We want to put a pillow behind their back, one between their legs, one under the upper arm, adjust the one under the head. Make sure the pillow is over that bottom hand. So it's hand, pillow, head, and call light goes in that bottom hand. Foot care, just like hand and nail care, a little lower. We're going to soak the foot, wash the foot, rinse the foot, dry the foot. We don't do anything with toenails, but look at them. You're going to apply lotion everywhere but between the toes. No lotion between the toes. Wipe off that excess lotion and put their sock and shoe back on. Make sure you're looking at the foot. That's the whole reason you're there. Mouth care, brushing teeth. Get them in a sitting position. Put a towel over their chest. Wet the toothbrush. Brush everything they've got. Let them rinse and spit as much as they need. Leave their mouth dry. That is the number 1 step that's missed on this skill. Make sure you look at your patient, leave their mouth dry, and then clean up. Respirations, don't tell them you're counting them. You don't want to tell your patient, I'm counting your breathing. They'll breathe funny. So respirations is the act of breathing. We're going to count how many times they do that over 1 minute. Normal is between 12 and 20. In and out counts as 1. In and out counts as 1. It's not in 1, out 2. In and out counts as 1. Good. This is a documentation skill. Range of motion. We're going to follow the recipe on the care plan. Whatever body part, whatever exercises, and how many repetitions is what we're going to do. Flexion, extension, up, down, abduction, adduction, side to side, rotation, not on the test, but it's around. Support the joints from below with a flat palm. Always return to start. A full range of motion. If you start here, you're going to end here, not here. Got it? Okay. Denture care, mouth care with an extra step. So we're going to clean the dentures. You want to put a washcloth in the bottom of the sink just in case they fall. Use cold water. You're going to brush both sides of the dentures, rinse it, store it in water in a denture cup that's been rinsed out. So we want to dump the water, get new clean water, put the dentures in, put a coaster or paper towel underneath, and put it on the bedside table, and then do mouth care. Ambulate with a gait belt. This is walking somebody. Look how much you've learned, guys. This is walking somebody. We're going to walk them as far as our care plan says, but remember that's round trip. So if it says 10 steps, it's 5 steps in one direction, 5 steps back. So you're not walking very far here. We are going to use a gait belt for this. When you stand them up, make sure they're okay to walk. Make sure you've removed all obstacles out of your way. Once you stand them up and ask if they're dizzy, you're going to walk with them slightly in front of you, holding onto that gait belt in an underhand grip. Pay attention to your patient. Return them to the chair. Make sure they can feel it. Help them sit down. Remove the gait belt. That's an easy skill. And then partial bed bath. Jake, can take that down for just 1 second. And I'll read that in just a second. This is our last skill that we learned was partial bed bath. We're going to use the leaves method for this. Face first, no soap. So we're just going to rinse and dry the face. Then we're going to wash neck or under the chin, across the neck, chest, abdomen, up the side, down one arm and hand, up the back and armpit last. Rinse that. Change the gown, turn the patient over. You're going to wash the back, rinse the back, dry the back, little back rub with lotion, wipe off the lotion, tie the gown, clean up. Super easy, long skill. All right, Jake, go ahead. Anna. Hey, Miss Pat, I passed my exams on the first try. Thank you. Your lecture really helped me. Congratulations. Great job. I'm super proud. Thank you for including us in your journey, and we wish you the best of success in your new career. All right, flashcards will help you. Remember that for you guys sitting in this classroom, you're getting them for $14.99 through next Wednesday. If you decide to buy them after graduation, you'll be paying the full price. What all those people have to pay, $24.99 on my website. All right, so we have 3 skills we're going to learn today. And you're going to have some practice time built into class today as well. You probably will have about an hour, maybe a little bit more of practice time in class today. I think last time we were able to get like an hour and 15 minutes in. So let's see how long it takes to get us there. First skill we're going to do is transfer a resident out of bed and into a wheelchair. This is on page 72. You can see all the principles involved. We already know all of them. The only thing that we need to learn here is skill-specific steps. So if you look at the bottom of the page, you can see that somebody with your level of experience, which is none, should be able to do this in 11 minutes or less. You're getting somebody out of bed and into a wheelchair, and they're giving you 11 minutes to get that done. That's way more time than you need. In reality, 7 or 8 minutes really is what they should be giving you for this skill. So it's I can do this in like 3. Okay. way more time than you actually need. So don't rush this one. There's a lot of little details here that we have to pay attention to. You go to page 73, at the top of the page, you'll see your care plan, step-by-step instructions, and your supplies are at the bottom. And here's our care plan. It says to transfer the resident from bed into the wheelchair. The resident is unable to walk or take steps, but can stand with support. A gait belt or transfer belt is required to transfer the resident. The resident will stay in the room. So that's our care plan, and we know that we have to follow that care plan. Hey, Jake, can you get me the wheelchair, please? Over there. You'll have to turn the camera as well. And then I need you to take a couple of photos for that, that thing. Yeah. Oh. Okay. So you just leave it there. All right. So we know all of our principles. There's nothing new here to learn. We know all of the principles, but we are going to have to learn the skill specific steps. So I'm not going to be able to show you over there and do the buttons at the same time, but kind of bear with me. Okay. This is wheelchair 101. So I'm going to explain to you all of the different parts of the wheelchair. So do it lengthwise. Yep. Do that. And then I need you to zoom in for me. Okay. So wheelchairs are, most of us know a little bit about wheelchairs, right? They have big wheels. They've got a seat. People sit in them. But there's a couple things on the wheelchair that we have to be aware of. First of all, we have brakes. These little levers here are brakes. Every wheelchair is set up a little bit differently. Some wheelchairs, if you pull the lever back, it engages the brake. This one does that. Other wheelchairs, you have to push it forward to engage the brake. It's set up just a little bit differently. When you go to your testing center, they will show you how to work the brakes on the wheelchair at the testing center if you get this skill. They're not going to show you if this isn't one of your skills. But what happens here, see here, oops, let me back up. So what happens here is we have the wheel and then we have this metal bar here. And right now there's a gap. I can actually fit my finger in the gap. When I pull this back, that metal bar bites into the wheel and that's what keeps it from moving. There's one of these on both sides of the wheelchair. Okay. So this one, it's engaged and it's disengaged. Now in front of that are your leg rests and foot pedals. Foot pedals simply fold up and down. But this is not how we position them to get patients in and out of the wheelchair because those leg rests can still pose a tripping hazard. So these leg rests right behind where they attach onto this post, right behind is a little catch. And if you release the back of the catch, they spin forward. Now we have a wide open area for our patients to be able to get in or out of the wheelchair. Don't try to transfer somebody with the leg rests in this position because it's a tripping hazard. So when you're transferring somebody into or out of the wheelchair, safety is really what they're grading us on here. Okay. So you just release the catch. Now these actually just come right off. They sit literally on these little posts. There's just two little posts here that these sit right on top of. So it doesn't take much for them to come off. When you're working in a facility, chances are you're going to have a whole lot of wheelchairs without leg rests because they get taken off to clean. They go into a room somewhere. Nobody knows where they are, can't find them. That's a problem. We're going to see why in just a minute. Okay. Bring us back over here. All right. So there's three main positions for wheelchairs. This is when your patient is in it. We've got the foot rest down to support the feet, leg rests are forward, and the wheelchair is set up for motion. When we're storing a wheelchair, only storing, the foot pedals are up and the leg rests stay forward. And that's because over here, if I'm going to store this wheelchair, if I pull up on the seat, the two halves come back together, okay? If I'm going to store the wheelchair, I want it collapsed. But do you see how those leg rests can kind of fly all around? They're not secured. These can hit people when you're moving a wheelchair. So when you're moving, when you're storing a wheelchair, these are in this position. So the foot pedals are up. The leg rests are locked in place and my wheelchair is collapsed. And now I can move this and it's secure. It's not going to injure anybody. Okay. So when your wheelchair is being stored, it's leg rests up, or I'm sorry, leg rests forward and foot pedals up like this. When you're transferring, putting somebody in, taking somebody out, everything has to be out of the way for that transfer. You might have a question on the state exam that gives you some images and asks you which of these is appropriate when you're transferring a patient into a wheelchair. And you would want to pick the one that has the wide open space in front. No tripping hazards. Good? Okay, let's talk about your scope of practice for a second. I felt so bad for this woman. I really did. So there was a lawsuit in Georgia, and I'm going to kind of paint a picture for you. There's an older woman there with her daughter getting in an outpatient place, getting some x-rays or something like that done on her. And she was in a wheelchair because she was having trouble walking. So she's in a wheelchair. They take her back. They do the x-rays, put her back in the wheelchair, bring her back up front. She's ready to go home. And her daughter goes and gets the car and brings it right up front. So, you know, she doesn't have to walk very far. And they call for a transporter to take the woman in the wheelchair out to the car and help her in the car. Well, transport doesn't come. The daughter is sitting there in the driveway, blocking in the car. The woman is in the wheelchair inside, and a receptionist sees all of this. And the receptionist thinks, well, I'm just going to go out and help. You know, we'll get the woman in the car and, you know, that way they can get going and they're not blocking anything. So the receptionist takes the woman in the wheelchair out to the car, but she had never been trained on how to use a wheelchair. This was not in her scope of practice. And her wheelchair was positioned like this. She put the foot pedals up. She didn't know anything about the leg rests. So the woman's trying to get out of the wheelchair and into the car, and there's that leg rest in the way. Her feet get all tangled up into it. She trips and she falls and gets pinned between the car and the curb. And she breaks her leg. Now, the facility was sued. The receptionist lost her job. Now, she was just trying to do a good deed. She was trying to do the right thing. But she wasn't trained to do that thing. And something this simple, we all think we know how to use a wheelchair, right? It's something any one of us would have done without training because we're not aware that there are things that we don't know about wheelchairs. We count on the things we do know and think we're trained. Make sense? You don't know what information you're missing. You don't know what you don't know. So don't step outside of your scope of practice. If you haven't been trained, even if it seems very simple to you, you haven't been trained. The answer is no, because accidents happen. Does that make sense? This was a very large lawsuit. Very large. So be careful here. And I really feel bad for this receptionist because her heart was in the right place. She wanted to do the right thing. But it turned out very bad for the patient. Does that bring the patient comfort? Now, when I tell you that this older woman who broke her leg, she never walked again because of this. This had a serious impact on the remainder of her life. So good intentions aside, this was a big mistake. Make sense? Okay. All right. So now I want to talk to you about those foot pedals. So those foot pedals are way more important than you think they are. If you have a patient in a wheelchair, you should never have their feet just dangling down there. Feet have to be supported in the foot pedals, and this is why. In your body, and we kind of saw this with nerves. Do you guys remember me talking about that sciatic nerve? Well, nerves follow blood vessels. So we have red is arteries. We have arteries bringing blood all the way down to the foot. Blue are veins bringing blood back up to the heart. So they're two separate systems, but they lay one right on top of the other. Okay, so one goes down, the other comes back up. Well, both of them right here at the knee, it doesn't have a lot of padding there. It's just basically skin over a little bit of muscle, but blood vessels. Okay, so you've got an area of weakness here where we don't have a lot of padding. That's actually right where your knee bends. Okay, so we have veins that are super close to the surface right here, right behind the knee. And when we sit in a wheelchair, the seat actually compresses those veins. It squishes them down. Now, if you remember me saying along the way that blood that slows down or stops clots. So when we have a patient whose legs are dangling, they're just not touching anything, that seat is going to crimp down those veins, which means blood can't get back up to the heart. When that happens, we end up with swelling. But we also increase our risk for blood clots because of that compression. So when you have a patient who's in a wheelchair and their legs are just kind of dangling down, not touching the floor, not resting on anything, you will get swelling in those legs, but you will also improve the ability for blood to clot. This is what's happening on the inside of your veins. Now, veins are pretty unique. I think veins are amazing creations. They have to get blood from your feet back up to your heart. Gravity is trying to pull all of that blood back down. So they have to fight gravity. Veins fight gravity. And the way that does this is inside your veins are these little valves. So when your heart beats, blood gets pushed up from one compartment to the next, your heart relaxes and the valves close. So now I've got blood in this compartment. Next heartbeat, this blood is going to be pushed up through the valve into this one. The heart relaxes, the valve closes. So your blood actually climbs a ladder to get back up to your heart from your veins. Pretty cool. That's a pretty neat little system, right? Well, the problem is that these valves, when they get squished, they hold blood cells there. That is where blood clots occur. So we can avoid all of this by simply making sure that when we have a patient in a wheelchair, we have their feet supported on those pedals. That relieves the pressure up into the backs of the knees, allows blood to flow, and relieves the risk of blood clots. Foot pedals are way more important than you think they are. So if you're working with a wheelchair and those leg rests are missing off of the wheelchair, you should not put a patient in it. If you have no way to support those feet, you're putting your patient at risk. Good. Now, there is a different kind of wheelchair called a companion chair. I'll read that in 1 second, Jake. Called a companion chair. Companion chairs are different than wheelchairs. Wheelchairs have big wheels. Companion chairs have 4 of those little wheels. 1, 2, 3, 4. And they're lower to the ground. They're specifically designed to be able to pad. So your patient can sit in that, their feet are flat on the floor, and they can use that to move themselves anywhere they want to go. It's kind of 4-wheel drive. They're pretty cool little chairs. But the point is they're lower so you don't get that venous compression on the back of the knees. Okay. So Exotic says, hey, Miss Pat, I'm about to take my skills test. I'm in high school. Your videos help me and my classmates to get where we are today. Thank you. Oh, how exciting. Good vibes out to you. You're going to do fantastic. I have faith in you. Just remember everything that I've taught you. Do your opening. Make sure you wash your hands before you touch the patient. Make sure you wash your hands at the end. And above all, follow the care plan. But you'll do great. Let us know how you do. We'd be happy to congratulate you. All right. You guys understand why foot pedals are so important? Okay. When you are transferring a patient from bed to wheelchair, the wheelchair has to be close. And when I say close, I mean close. Like I should only be able to fit a piece of paper between my patient's knee and the wheelchair. That's it. If I can fit anything, if I can fit a pencil in there, too far. A piece of paper is all you should be able to fit between your patient's knee and the wheelchair. Okay. So as you can see, this is way, way, way too far. But I have to be able to get my patient sitting up on the side of the bed before I transfer them, because at the beginning of the skill, your patient is laying down in bed. So if I have that wheelchair as close as I need it, there's no room for their legs. They're going to hit the wheelchair. So for this skill, you want the wheelchair within reach, but not close to the bed. We're going to get our patient sitting on the edge of the bed, and then we're going to bring our wheelchair super close before the transfer. In the meantime, I have to get shoes on and a gait belt on. So wheelchair, arm's length away, pivot your patient, shoes, gait belt, and then we're going to bring that wheelchair super close to the patient where it's almost touching them. Foot pedals and leg rests are tripping hazards, and this is a tested checkpoint. It asks us if we have moved the foot pedals up and the foot rests out of the way before we transfer the patient. This is a critical testing checkpoint. If this is all you miss on the state exam, you will fail. One step can fail you. Why? Why would that one step fail us? Yeah, absolutely. We put our patient at risk. Pivoting a patient to the side of the bed, everybody thinks they can't do this, and I'm here to tell you you can. You don't have to have a lot of upper body strength here because we're going to use momentum to help us. When you're pivoting a patient to sit on the edge of the bed, like if I'm going to turn this patient, I would pull the sheets out of my way. This arm is going to go underneath the patient as far under it as I can get. So their furthest shoulder should be in my palm. I'm not just going to put my hand a little bit under like this. I want this arm all the way under that patient. This is a key, all the way under. Now, this arm is not going to go under the legs. This is what most people try to do. They try to put a hand under the legs. That doesn't work. You're going to put your hand over the legs. So this hand is going to push up. This hand is going to slide toward me, and it looks like this. And your patient just pivots to the edge of the bed. Now, you want a wide base of support when you do this. Your feet should be at least shoulder width apart. You should be bending at the knees, not at the waist. And if you check to make sure the bed is locked, but if you lean against that bed, it provides torque. So you end up with more strength and momentum to get them sitting on the edge of the bed. But it's a pretty quick turn. So when you get the patient sitting on the edge of the bed, put your hand on their back, step away and just, are you okay? Feeling okay? It's a quick turn. Dangle a minute, get your bearings, and then you can put their shoes on and their gait belt. Doesn't matter which one comes first. Shoes, gait belt, shoes, nobody cares. All right. Dangling helps minimize falls, and it's a testing checkpoint. We're going to put our gait belt on, checking to make sure it's snug, and you're going to bring the wheelchair close. Now, do you see how close that wheelchair is? It's still way too far away. I can fit more than a piece of paper in there. I can fit an entire fist in there. So I need that wheelchair way closer than this. Good. Before you transfer a patient into or out of a wheelchair, you have to make sure it is locked. This is critical. Because if I try to put somebody in that wheelchair and it's not locked, it's going to roll away and your patient's going to end up on the floor and you're probably going to be on top of them. So lock that wheelchair. Make sure they have shoes on. And you're going to use that same body mechanics we use for ambulate. 1 foot parallel across their feet, 1 foot perpendicular across their feet, 1 foot parallel to their body, like this. And you're going to use that gait belt to stand them up, pivot them around, and then sit them down in that wheelchair. And they have to be able to feel that chair behind them before they sit. Support the feet with a footrest to prevent blood clots and swelling. And then you can remove that gait belt. When you remove the gait belt, don't slide it against them. You want to loop it up and over to make sure that you don't injure their skin. Now, at the end, our care plan actually says they're going to stay in the room after this transfer. If your patient's going to stay in the room, we don't want them looking at a blank wall. It's just boring. Turn them around so they're able to see the world or look out a window or something like that. But if I've got the patient, if I've swung them around, transferred them into the wheelchair, they're facing that wall and there's nothing to look at there. So turn them around. Make sure that they have something to entertain themselves. It's a tested checkpoint. Make sure that they're positioned properly. So now we know all of the steps involved. We're going to use those steps to check off our checklist. We're going to follow our care plan. We're going to do our opening. Knock, knock, knock. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to transfer you into a wheelchair. Is that okay? Close curtain, wash hands, get my supplies. I'm going to evaluate if I need gloves. I might, if there's body fluids. I probably won't for the test because they're fully dressed. But whatever applies to this patient. We're going to use the shoe rules that we've learned. We're going to make sure they have shoes on, check the snugness of the gait belt, count to 3 before we lift, make them a partner, all of those things. We're going to use the rules we just went over, and we're going to do our closing. That's how we're going to pass this skill. Now, this care plan is only for this patient, not for these guys over here. These guys would probably have a different care plan with transferring because some of them can walk, some of them can't bear weight at all and need a mechanical lift. Some of them are ambulatory, they move themselves. Every person's going to be a little different. And we're going to see how this all plays out. This is one I definitely recommend that you practice here because we have the wheelchair, we have the space, we have the gait belt, everything you need to practice this skill is here, and you'll have practice time built in today. Yep.
Hello.
Good afternoon, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. Would you like to get out of bed and into the wheelchair?
Yes, that'd be great.
Okay, I'll be happy to help you with that. Let me close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'll grab the gait belt. And I'm going to bring the wheelchair within reach, but not too close to the bed. All right, Mr. Jones, I'm just going to remove your sheet. We'll pull it all the way to the end of the bed. And I'm going to help you sit up on the edge of the bed. So to do that, can you scoot your body toward me? That is locked. You're going to cross your arms over your chest and relax. I'll do all the work. I'm just going to pivot you around so you're sitting on the side of the bed. Please let me know if you get dizzy or unstable at all. So I'm going to wide base of support, leaning against the bed, making sure the wheels are locked. I'm going to place one arm all the way under the shoulders and the other arm over the knees, bending at the knees, not the waist, and we're going to pivot. 1, 2, 3. Good?
Yes.
Okay, you can relax your arms. I'm going to help you put your shoes on now. Okay, first shoe and the second shoe. And are your feet flat on the floor?
Yes.
I'm going to place this gait belt around your waist, making sure that it's not twisted or kinked. And we'll secure it by sliding the gait belt into the first guard, pulling it so that it's snug. We'll check it with 4 fingers, and then slide it through the second guard. I'm going to bring the wheelchair close at a slight angle, almost touching the patient. And we'll lock the wheels. All right, Mr. Jones, can you bring your feet together and back a little? Are your feet flat on the floor?
Yes.
You're going to place your hands on my shoulders. I'm going to lift you to a standing position, pivot you, and when you feel that seat behind your knees, I want you to say sit, and I'll help you sit.
Okay.
Okay, you're going to place your hands up here. And on the count of 3, we're going to lift and pivot. 1, 2, 3.
Sit.
And we'll remove that gait belt. Okay, and I'm just going to bring the gait belt behind you and turn you around to get your feet onto the foot pedals. So we're going to turn around. I'm going to bring the first foot pedal forward
Make sure it locks into place, and then place the foot on the foot pedal. We'll then lock the wheelchair. I'll lock this side, support your leg, bring the leg rest and the foot pedal, and support the foot. Are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Let me get your call light. Here's your call light. If
Thank
you need anything at all, just press that red button and somebody will be happy to come help. I'm going to open the curtain and go wash my hands. On the way, I'll return the gait belt to storage. After washing my hands, I'll think about my skill, make any corrections, and tell the evaluator my skill is done.
All right, any questions on that one? Any questions? It's one of the easier skills, but unfortunately, a lot of the checkpoints on that one are critical checkpoints because they're safety. So this is one you probably need to practice in here where you've got all of the supplies and the space to do so. We're going to go ahead and take our break a little bit early. Instead of doing 2 skills, I'm going to take the break now because the next 2 skills both have a lot of lecture involved and it would take us past our normal break time. So we'll break early today. We're going to do the last 2 skills. There's a lot that I have to tell you about each of them. And then we'll sign off of online and you'll have the rest of the class to be able to practice what you've learned, okay? There is a pastry back there that I brought in today. Please help yourself, please. Please eat it up. So we'll go ahead and go on break and we'll be back in 15 minutes. All right. We're going to move on to the next skill now. And the next skill is one of the easier skills. It's feeding a resident who's in a chair. So your patient's going to start out sitting in a chair at an overbed table just like this. It's not a hard skill. I'm going to go over some particulars with it. But there's not a whole lot here to teach you about eating itself. We all know how to eat. You can pretty much figure out how to feed somebody. But there's a lot of things about this skill that are not as intuitive as you would think. So there's some really small details I have to go over with you with this one, which makes it a little bit longer lecture. So if you go to page 109, you can see our care plan at the top of the page, followed by step-by-step instructions, and your supplies are at the bottom of the screen. So if you'll notice at the bottom where the supplies are, you'll see meal tray. This is already going to be prepared by the evaluator before you ever start this skill. On that tray is going to be a cup of water, a napkin, a spoon, a fork, and a single-serve food item like pudding or applesauce. That's what you're going to be feeding your patient. The food tray is already prepared. Now, for the test, you do not have to verify that the food tray matches an order, a diet order. I think that they should do that, but they don't. They don't make you verify the food tray. But you do, Chapter 8 is going to go over that you do need to be aware of it. So our care plan for this says to feed a resident a snack who is unable to feed him or herself. The resident is sitting in a chair in an inappropriate position for eating. You might want to underline that or highlight it. In an inappropriate position for eating. So no matter what your eyes tell you, your patient is not in the right position. Okay? Care plan says, if you are the patient for this skill, you are going to get some very specific instructions. So let's say that you are picked to be a patient for you to feed, okay? You are going to be told, I want you to go over there, sit in the chair, and I want you to either slump or slouch. Don't be sitting up straight. You're only going to take 4 bites, and then no matter what she says, just say you're done, you're full, you don't want any more. So 4 bites is all you're going to take, okay? That's your instruction. Now, she doesn't hear any of that. That goes directly to you. But your idea of slumping or slouching might be different than your idea of an inappropriate position for eating, okay? So you might do something like this. Well, this doesn't look inappropriate for eating. In fact, have you ever seen a 12-year-old eat? They all eat like this, okay? Like their head is too heavy to hold up. We are used to seeing that, so that doesn't look inappropriate to us. But what does our care plan say? They're in an inappropriate. So it doesn't matter what your eyes tell you. You have to tell the patient, can you please sit up straight? Can you please sit up? Good? Make sense? All right. It tells us to document the intake on a food and fluid intake form. So keep your finger here for a second and go to page 169 in your book. Page 169 has the food and fluid intake form. This is what you're going to get for the state exam. This is how the exam, how the form will look. And if you're on page 109, if those of you who are joining us from home, you can see the form there in the second column, right in the middle. So that form is going to have you check off a box to indicate if this is a meal or a snack. What does our care plan say? Snack. So you want to check off snack. It's going to ask you a percentage. How much did this patient eat? How much did this patient drink? These are percentages, and we're going to go over that in a few minutes. I'm going to explain to you how to do percentages in a few minutes. There's nothing new to learn here. We know to read the care plan. We know to do our opening. We know to evaluate if we need gloves. We know not to hold anything next to our uniform, and nothing goes on the floor, and we know to do our closing. There's nothing new here. But I do want to talk about gloves real quick. Unless there is a specific reason to wear gloves, you should not wear gloves when feeding somebody. Latex gives off an odor. That odor is an appetite suppressant. It will affect the appetite of the patient. You are on the other end of a spoon. You are not in the patient's mouth. There is no need for gloves unless there is a specific need for gloves indicated in the care plan. Make sense? It's also very emotionally off-putting to patients if you are wearing gloves while feeding them. It'll affect how they eat. Now, the reason for that is very psychological, and I want to spend a moment talking about this. This is the hardest skill to be a patient for in real life. I'm not talking about when you're playing around, feeding each other. I'm not talking about that. I'm talking about if you lose the ability to feed yourself for real, it affects you psychologically in a way that no other skill does. It's harder to be fed than it is to have Peri-Care done. That is because psychologically, eating is the very first skill you become independent at. You learn how to hold a bottle long before you know what hungry is. You are picking up diced peaches and Cheerios off a high chair tray and putting them into your mouth before you can even sit on your own. Eating is the first skill we develop independence with. And when you lose the ability to feed yourself independently, it affects you psychologically in a way that no other skill does. People that have to be fed generally will not eat well. They often suffer from failure to thrive. Depression goes along with this, and we don't want to do things that are going to make this harder for the patient. Does that make sense? Okay. So when you have to feed somebody, you have to go out of your way to turn up the nice. You're going to sit, not stand over them. If you're standing over them, there's a power dynamic there. But it also makes them feel rushed. It makes them feel like you've got something better to do than feed me. Make sense? Okay. You want to have a conversation. People talk while they eat. No, you do not talk with your mouth full, but you still have a conversation while you eat. Have you ever gone out to eat? When you walk into a restaurant, is it dead silent? No, there are conversations happening everywhere. In fact, restaurants is one of the loudest environments. And it's because we have conversations. You ask me a question, I chew. When I swallow, I answer the question. You take a bite and you chew while I'm talking. And we go back and forth that way. But conversation is a very big part of eating. And if you don't have anybody to have a conversation with while you're eating, you probably have the TV on. Or you're flipping through social media. Or you're reading the back of a cereal box. You are entertaining yourself in some way while you're eating. Those two things go hand in hand. But eating actually is part of our social fabric. Think of all of the milestones in somebody's life. You have birthdays, food, gathering of people together, talking, laughing, eating. Graduations, gathering together, food, talking, eating. Baby showers, weddings, even funerals are social gatherings centered around food. Socialization is part of the eating ritual. And if you don't socialize the patient, they are not going to eat well. So talking to them is actually a bigger part of this than you realize. And it kind of goes into what we were talking about during break. Do you have to say everything that I say when I'm teaching you these skills? And the answer is no, it's not a checkpoint to say everything I say, but you should, because your patients don't know what you're doing with their bodies. Keeping them informed is an important part of what we do. You have to think about their mindset. Okay? Make sense? All right. So this skill has a lot of psychology in it that's not real apparent at first glance. And that's kind of what we're going to talk about when we talk about the skills specific steps. So feeding doesn't follow all of our normal rules. Like, we're not going to put a barrier on the table because your food tray is your barrier. You don't need a chucks on the table because you have a food tray. So no barrier is used. We don't close the privacy curtain because eating is a social event and you don't want to isolate the patient. When you close that privacy curtain, it isolates the patient. And again, you have an impact on their eating, their intake. You have to sit while you feed them so that the power dynamic is equalized, not unequal. And then you have to have a conversation because that socialization is part of what we do. Care plan says your patient's not sitting up, so we have to ask them, can you please sit up straight for this skill? That's all you have to do is ask, but you have to recognize it for the test. You're going to offer them a hand wipe and a clothing protector. You're going to offer it. They don't have to take it. Me, I need a clothing protector. I wear everything that I've eaten. In fact, I've got some stuff from break just a minute ago. I wear everything. So if you offer me a clothing protector, I'm going to say, yes, please. I need it. Sure. Now, my grandmother, very, 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 very prim and proper. You offer her a clothing protector and she'll tell you in no certain terms, I am not a child. We offer, but whatever they want, it's perfectly okay. Okay. We also offer a hand wipe because most people have been trained to wash your hands before you eat. It's part of the eating ritual. It actually helps stimulate the appetite. But also it's infection control, because just because you are feeding them does not mean that they can't move. It doesn't mean that they can't wipe food away from their mouth, and we don't want dirty hands up around the mouth while we're feeding. So that hand wipe is for infection control, but also for ritual. So we'll offer both. Would you like a clothing protector? Would you like a hand wipe before we get started? We're going to be nice. We're going to offer both. They can say yes, they can say no. Either is fine. You're going to pull up a chair. For this skill, there will actually be a chair in the area for you to use. You're not going to have to go far for it. The evaluator's job is to set the scene. But that evaluator isn't going to put the chair right here because it'll be in the area, but they want you to recognize that you need to sit. They're not going to cue you into that. Make sense? Good? All right, so you have to sit for this one. Now we're going to offer a drink before we feed them and every 2 or 3 bites. This is because everybody has different preferences. Some people drink before a meal. My aunt was like that. She would drink an entire glass of water before she ever ate anything because she swore it filled her up and she ate less. And she was a model when she was younger and learned that trick. That has never worked for me. Never worked for me. I'm the type of person that has to drink while I'm eating. I take a bite, I take a drink. I take a bite, I take a drink because I don't produce a lot of saliva and I need that moisture, to chew well. So I drink with my meal. Now, my husband's completely opposite. He doesn't drink before and he doesn't drink with. He'll drink after his meal. He likes his glass of milk after the meal. Everybody has different preferences. We don't really stop to think about how the way we eat differs from the way other people eat. Here's another one that you probably haven't thought of. How many of you guys don't like your foods to touch on the plate? Do I have anybody in here that don't like your foods to touch? Okay. How many of you like your corn and green beans, corn and mashed potatoes mixed? Yeah. Okay. How many of you eat all of one thing on the plate before moving to the next thing on the plate? Okay. All right. So did you notice that not all of you raised your hands for all of those things? What does that tell us? Everybody's different. So the way that we eat is not necessarily the way your patient eats. We are there to be their hands, not their brain. So we want to ask, what would you like first? What would you like next? How do you like to be fed? How do you like to eat? Now I'm going to tell you a story about this. When I was in hospice, I went to a facility, a long-term care facility, to see one of my patients. And we're going to call her Mary. And Mary, I was seeing her because she had end-stage cancer. Unfortunately, it was terminal. Wasn't much we could do about it. But she had also had a stroke some years before that left her nonverbal. She wasn't able to speak. Didn't mean that she couldn't think. She just couldn't speak. And she was very expressive. I mean, her face could tell a story. So I go into the facility on this particular day, go in to see Mary, and she's down in the dining room and she's being fed. So I walk up to the table and there's 3 residents sitting there and 1 CNA who's feeding all the patients. And I walk up and I tell the CNA, hey, I'll feed Mary today. I'm here. And so I, said hi to Mary and I sat down and I look at her plate and it's this big gray glop of goo. That's the only way to describe it, right? It's just gray, mushy something. And I looked at the CNA. I'm like, what are they feeding them today? What is the menu? And she says, oh, it's Salisbury steak, mashed potatoes, and I think beets. Okay, but what is this? She said, Salisbury steak, mashed potatoes, and beets. I said, together? She says, well, yeah, it's pureed. I said, would you eat Salisbury steak, mashed potatoes, and beets all mixed? She says, oh, God, no, that's gross. So why are you feeding it to another human? She says, oh, well, it's pureed. They can't taste it. No, pureed means chopped up, not no taste. It has all the taste, just none of the chew. She says, oh, well, that's gross. Really? Let's get a new tray for Miss Mary. Now, in the meantime, Miss Mary is like rolling her eyes and tossing her head and telling me that she does not like this gray goop. So if I had not been there and intervened, Mary probably would have refused her meal. Not because she was refusing her meal, but because what was being served was unpalatable. When we have people that can't speak to us, especially about something as important as food, we probably need to pay attention to their nonverbal cues. Make sense? Okay. Food is very, very individualized. There are things that I absolutely love that you guys probably would not like. And there are things that I absolutely don't like that you guys probably love. Right? Everybody has different tastes. But what we eat is part of our identity. And when you stop paying attention to that, when you stop honoring that, your patient feels like a number. They just feel like another job. And that's not how we want our patients to feel. Good? Make sense? Okay, so for the exam, we're going to offer a drink before we feed them. They can say no. And we're going to offer a drink every 2 to 3 bites. They can say no. That's fine. But remember, I gave you very specific instructions. I told you to take how many bites? 4 bites. So we're going to offer a drink every 2 to 3 bites. So by the time we get to 4, if we didn't offer a drink, we don't get that check mark. Because she's going to say, I'm done after that. Good? Make sense? Yeah, got to offer that drink. Yep. We're going to feed slowly. And the spoon should only be half full. So we're only offering 4 bites and the spoon is only half full. So they're not eating a whole lot for the test. We're showing that we understand the process. We're not feeding them a whole thing of pudding or applesauce. Okay? Have a conversation. Doesn't have to be a real one. You can make something up. You can talk about, the fireworks on New Year's Eve. Did you see the fireworks? You can talk about Valentine's Day is coming up. You got any plans for Valentine's Day? I hear they're handing out some candy in here. I hope I can get my hands on some of that. Yeah, you can make something up. I don't care what you talk about. Talk about a bingo game that's coming up. Talk about a movie that's showing on the big screen. Talk about anything, but you have to have a conversation for the test. In a real life setting, I focus on them. I look around the environment. Most people have pictures. Who's that couple on the wall? Did you know them? Were they movie stars? They are gorgeous. Watch her sit up a little straighter. Oh, honey, that's me. I've just made her feel good. That's going to impact her appetite. She's going to eat well now. Look around. Ask them questions. One of my most common questions that I ask is, what's the most exciting place you've ever been? Think back over your life. What's the most exciting place you've ever been? Now, everybody's got a different answer for that. But most of you probably have 2 or 3 trips in the back of your mind that you're thinking about. It could be this one. Oh, maybe it was this one. Oh, I don't know. You now are reminiscing, which gives me a ton of opportunities for conversations. But I'll tell you, one of the most interesting conversations I've ever had was with somebody who didn't think she had anything interesting to say. This is up in Citrus County when I lived up there. I went to an assisted living facility and I was working on a patient who was in her late 90s. She was still sharp as a tack, but she had these horrible leg wounds. And this is going to take me about 45 minutes to do this dressing change on these legs. So I pull up a chair and I asked her, so what's the most exciting place you've ever been? And she says, oh, honey, I've never been anywhere. I said, never been anywhere? Well, we're in Citrus County. You had to have gone somewhere. She says, no, I've never left the county. Wait, hold up. You are in your 90s and you've never, ever, ever left Citrus County, ever? You never went to Ocala? She says, oh, no. She says, well, it's not entirely true. I was born in Brooksville, but I don't remember that. Citrus County, you've never left? This is living history sitting right in front of me. Tell me everything that you remember. She remembers when there were no paved roads in the county. She remembers when the first McDonald's came in, when the first car dealership came in, when the 2 families in Inverness that fought like the Hatfields and McCoys, one of the daughters and the other's son were going to get married, and that was supposed to kind of help. And the daughter ran off with the boy next door. And what a scandal that was. This is living history. This is someone who doesn't think she has anything to contribute. And it's one of the most exciting conversations I've ever had because that was my home county. And think about all the things that she has seen. It was amazing. I left there, called up my agency and said, send me back. This woman is a riot. I love her. And I ended up seeing her twice a week for several months. Had lots of conversations. It was great. Everybody has a story. All they need is an opening. You don't have to carry the conversation. You just need to know how to ask the right questions. Okay? Yeah. The secret to being a great conversationalist is to close your mouth and open your ears. You will be known as a great conversationalist. During the exam, your patient's going to take 4 bites and then they're going to say, I'm done, I'm finished, I'm full, I don't want any more, no thank you. They're going to stop eating. Now, you are required to provide encouragement. I'm going to give you 3 ways you can do that. You need to do at least 1. I'd prefer if you did 2. So here are the 3. The first thing I ask is I turn up the charm because when I become charming, it's really hard to tell me no. Are you sure you don't want just 1 more bite? Come on, for me, please. Come on. I get to sit here just a few more minutes. And man, have I had a shift. 1 more bite for me. And people will take another bite because they think they're doing me a favor. The second thing I'll ask them is, do you want something else from the kitchen? You didn't eat a whole lot here. And we've all had those days where we make something, we think it's what we want, we take a bite and we're like, no, it's not it. Not what I was looking for. We can go back to the kitchen and get something else. They can't. So if they aren't eating real well, ask them, can I get you something else? Because maybe this just wasn't it. The third thing I do is I always tell patients that food is available. So they don't think that, they can't ask for food later if they get hungry. So I've got some crackers in the staff kitchen. So if you get hungry, just let me know and I'll be happy to get some peanut butter crackers for you. Right? We want to encourage that intake. So use at least one of those. Again, we're going to leave their mouth clean. I don't know what it is with this step, but everybody forgets it with mouth care and denture care and feeding. So make sure you leave their mouth clean and dry. I don't know what it is with that step, but people forget it. Have the clothing protector because you use that. Absolutely. Absolutely. Napkin, something. Yeah. So we are going to document for this skill. So we have to do our closing. Thank you very much, Ms. Jones. Is there anything else I can get for you? Your environment's clean. Here's your call light. Oh, the curtain's already open because we didn't close it. And go wash your hands. You're going to do your closing, but then you have to document. Now, this is a documentation form we're going to use. We are going to check off snack because it's a snack. The percentage is going to be based on what they ate. Now, remember, they're taking 4 bites and the spoon is only half full. So for the exam, it's probably going to be 25%. Okay, about a quarter of what we started with. Drink, though, could be anything. They may drain the cup because remember, it's another person that's testing and their mouth might be a little dry because they're nervous, right? So they may drain the cup. They may drink 100%. They may refuse it because, they don't want anything to drink. They really don't even want to be here today. We don't know. I have no idea what the liquid they're going to consume is, but food is probably going to be about 25%. So while we're talking about percentages, that's the next thing that I'm going to teach you. Before we get there, I want to just do a quick review here. We're going to sit while we feed. We're going to offer a hand wipe before feeding, offer a clothing protector, offer a drink before feeding, and every 2 to 3 bites, let them lead, feed slow, spoon only half full, and no childlike feeding techniques. No planes, trains, or automobiles. Not on the test. Now, there are patients that I have done that with because I use a lot of humor. I would not do that with my grandmother. No. But there are people that sometimes you can get a little laugh out of them and kind of lighten the mood, break the ice a little bit, but not during the test. Okay. So let's talk about meal percentages. Okay. When we are documenting intake, particularly food intake, there's a different type of intake we're going to talk about in a minute called intake and output. But when we're talking about food intake, we usually use this. This is what we call a quarter scale. 0 means they refuse. They didn't eat anything. That tray is going back to the kitchen in the same way that it came out. They didn't touch it. 100% means they're part of the Clean Plate Club. They ate it all. Now, they may leave a crust or a piece of broccoli stalk, not the crown part, or, a piece of Jell-O. They may leave just a tiny, tiny bit, right? But for the most part, they ate everything. Now, everything in the middle is what gets a little bit murky. This is where we tend to struggle. And this is an estimation. It's not designed to, it's not designed, I know we're posing here, guys. I have a podcast that I'm going to be a guest on Sunday, and they need some pictures for B-roll. So, yeah. So this is a very gray area, okay? But it's based on estimations. If they picked at it, ate a couple of bites, but didn't quite get half done, we call it 25%. If they ate about half, we're going to call it 50. If they ate most, but not all, we call it 75. We don't use 68. It's 0, 25, 50, 75, and 100. Whatever one they're closest to is what we're going to call it. Okay? Make sense? All right. So here's an activity to help put this into perspective. This is what we started with. We have a sandwich, some broccoli, and some Jell-O, which does not look like a good lunch. There should be chips instead of broccoli, I think. Yeah, broccoli and sandwiches don't go together, do they? But so this is what we started with, and this is what the patient left on their plate. So how much, using this scale, how much would we document on this? Yeah, probably 25%, right? They take a bite of the sandwich, maybe a little bit of the broccoli.
I'm blind.
Oh, sure. Come on a little closer. So they kind of picked at it. They didn't really eat anything measurable. Now this one, what's that? Yeah, they picked at the Jell-O. This one, okay, they ate about half of the sandwich. They ate about half of the broccoli. And they ate a couple of bites of the Jell-O. This is closer to 50%. Down here, they ate almost all of the sandwich. They ate almost all of the broccoli. And they ate about half of the Jell-O. This is closer to 75. And this one, we're going to give them credit for 100. It's closer to 100. Even though there's 2 pieces of Jell-O left and a little bit of broccoli, it's closer to 100 than it is to 75. Okay? So this is an estimation. All right, so now we have something called intake and output, which is a little bit different. It's much more scientific. Percentage is estimation. This is hard numbers. If your patient is on intake and output measurements, and this is on page 107, if your patient is on intake and output, that means that we are measuring everything that goes into the patient and writing it down, and everything that comes out of the patient and writing it down. So if your patient is on I's and O's, or intake and output, if they drink something, we have to document how much they drink. Now, in America, we tend to focus on ounces. But in medicine, we use cc's. So that means that we're used to measuring in one way, but we have to document in another. So if we're using prepackaged items like that Milo's iced tea, can you look at it real quick? On the container should be how many ounces? It's probably like 15.9. 20? Okay. Right beside that 20, though, or under it, the mLs. How many mLs? 600. So if we're looking at a pre-packaged item, it will have the amount of ounces, but it also has the amount of mLs, and that's what we're going to use is what's on the package. So that is 600 mLs. Okay. That can of Sprite over there. Can you tell me how many ounces is your can of Sprite? Should be 12.
Yeah.
Okay, how many mLs?
355.
355. So even though we can do the math to get the mLs, it actually tells us on there we're going to use that instead. So if they drank that whole can of Sprite, they took in 355 mLs. Make sense? The problem that we run into is when things aren't pre-packaged, like the cup of coffee is not going to be pre-packaged. Our cup of water or juice is not going to be pre-packaged. Now we know when we go to work, wherever it is we go to work, and we go through orientation at that job, they're going to tell us our coffee cups hold 6 ounces. Our water cups hold 8 ounces. Now, we can't document in ounces. We have to document in mLs or cc's. Same thing, mLs and cc's. Remember everything in healthcare, 2 names for 1 item. Same thing. So we have to know how to do the conversion. So we multiply the amount of ounces by 30 to get our cc's or mLs. So if we have an 8-ounce cup of water, we would multiply that 8 ounce by 30 and get 240 cc's. If we have a 6-ounce cup of coffee, we multiply 6, the number of ounces, by 30 to get 180 cc's.
Is there going to be
Yes. Yes, you will have, and that's what I'm getting to. There's two different types of math questions that you could have. We're going to go over that right now. So if you go in your book to page 106. Yep. Yeah, 1 ounce is 30 cc's. So if you look at this, this is another activity for estimation that you can do on your own, but I want to come down here to the bottom of the second column here. We have 6 ounces of juice. If we're going to convert that to cc's, we would multiply the 6 times 30. What would that be? 180. So write 180 in that space under 9. Write 180 there. Now, that milk carton actually tells us how many mLs are on it. So how many mLs? 240. So write 240 in that number 10 space. And then 12 ounces of coffee, man, that is a big coffee cup. But 12 ounces of coffee, if we multiply 12 by 30, we get 360. So you would write 360 there. Now, if your patient is on intake and output and we mark down everything that they took in, at the end of the shift, you have to add all of that up together. So in this case, we would have to add up 180, 240, and 360. And if you do that math, 180 plus 240 plus 360, you would get 780 cc's. So that would be the answer for number 12. On the written state exam, you will get one of these two types of math questions. It's either going to tell you to convert ounces to cc's, or it's going to ask you to add up several forms of intake into your total intake for the shift. So you will have a multiplication or an addition question on the state exam, but just one. Good? Questions? Questions? Okay, if you go to page 132, I want to talk to you guys a little bit about medical abbreviations. Everything that is highlighted in gray are things that you probably need to know as a CNA. So if it's in gray, you probably need to learn it. Well, let's start up here at the top, though, and I want to explain a couple things that isn't very intuitive. So up here, you see BID, TID, and QH. It's important to understand that these are abbreviated Latin, not abbreviated English. If you try to make sense out of it in English, it's not going to make any sense to you at all. It's all Latin. And that's because Latin is the language of medicine. So BID, B stands for bi. How many wheels are on a bicycle? 2. So B is bi means 2. So BID is 2 times in a day. TID, T stands for tri. How many wheels are on a tricycle? 3. So TID is Latin for 3 times a day. QH, Q stands for, and I'm going to butcher this because my Latin is very rusty, but quaque, which is every. That's Latin for every. And H is for hora or hour. So QH is every hour. What would Q2H be? Every 2 hours. Q4H, every 4 hours. And then you get down here to QHS. Now, what is that? HS is how they say bedtime, hour of sleep, or asomni, hour of sleep. So bedtime. Good? Make sense? Okay. All right. Then we come way down here to NPO, nothing by mouth. NPO is nothing by mouth. If your patient is NPO, that means that they are not eating. They are not drinking. We have something going on with them. Don't feed them. Good? Make sense? NPO, nothing by mouth. You need to know that one. There are many, many, many medical errors that occur because CNAs and other healthcare professionals don't know what the term means and they guess. Don't guess. If you don't know what the term means, ask. Hey, listen, I know we went over NPO in school. I don't remember what it means. What does it mean? I'd rather you ask than make a medical error and do something that the patient can't recover from. Good? Make sense? All right. All right, so page 169 has the form that we just went over. Page 107 is the lesson for intake and output. You'd probably want to make sure that you read that sometime between now and the test. So if you look at this, we know all of those steps now, nothing there that we don't know. So we're going to use those to check off this checklist. We're going to follow our care plan. We're going to do our opening. We're going to evaluate if we need gloves. We're going to make sure that we don't hold the linens up against our uniform. Nothing goes on the floor. We're going to sit while we feed them, offer them a hand wipe and a clothing protector. We're going to offer a drink before feeding and every 2 to 3 bites. Small bites. Spoon should be less than half full. Have a conversation, encourage the patient to eat, leave the area around the mouth clean, and we're going to document. And then we'll do our closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Bed's in the low position, environment's clean. Here's your call light. I'm going to go wash my hands and document, then wash my hands again. Good? This care plan is just for this patient, nobody else. Every care plan you have will be different because every patient will be different. So they give you a ton of time to do this skill, way more time than you actually need. How much time do they give you? What's on the bottom of this page? 9 minutes? Yeah, that's what I thought. They give you 9 minutes. You're feeding 4 half spoonfuls. 9 minutes is way more time than you need. I think the video takes me like less than 4 minutes, and that's with the opening and the supplies and everything and all the stuff at the end, the credits. So don't rush through this, guys. Don't rush. This is the one skill I really want you to slow down and make your patient feel a little more comfortable. All right? All right, Jake's going to show you this video.
Good afternoon, Mr. Jones. My name is Patty. I'm your CNA today. Could I ask you to sit up straight before we get started, please? How are you?
I'm good.
Fantastic. Would you like to eat a snack?
Yes, that'd be lovely.
Okay, I'd be happy to help you with that. Let me go wash my hands, get my supplies, and I'll be right back. Okay, Mr. Jones, I'll give you a hand wipe so you can clean your hands before we feed you. Okay, would you like to take the hand wipe?
Yes, please. Thank you.
And go ahead and clean your hands. Thank you very much. I'll dispose of this in the trash. And would you like a clothing protector?
Yes, please.
I'm going to go get one for you. Okay, Mr. Jones, I'm going to take this clothing protector and put it over your chest. This will just protect your clothing while I feed you. And I'm going to pull up a chair. How are you doing today?
Very good.
Wonderful. Would you like a sip of water?
Yes, please.
Okay. And we have cinnamon applesauce. How does that sound?
Great.
Wonderful. Here we go. We're going to fill the spoon less than half full. And do you enjoy sports?
Yes.
What sport do you like?
Football.
Oh, I do too. Did you watch the big game
I
yesterday?
was so happy my team won.
Oh, it was such a great game. I couldn't believe in that last quarter what happened. Another bite?
Yes, please.
There you go. Would you like a drink?
Yes, please.
Okay. Good?
Yes.
All right. Yeah, my favorite team doesn't win very often. Usually when I'm watching, they're guaranteed to lose.
Usually for me as well.
Would you like another bite?
No, thank you.
Are you sure?
Yes.
Okay. Can I get you something else from the kitchen?
No, thank you.
Okay, if you get hungry later, please let me know.
I will.
Okay. All right, I'm just going to take this clothing protector off. And we'll clean your face. I'm going to put this in dirty linen. I'm going to dispose of all the disposables. And we'll return the tray to the bedside table. Just going to move this to the side. And are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Let me get your call light for you. There's your call light. If you need anything at all, just hit that red button. We'll be happy to come help. I'm going to go wash my hands and document. After washing my hands, I'll document the amount of food the patient ate and the amount of fluid that they drank. Once I'm done documenting, I'm going to go wash my hands one final time. After washing my hands, I'll think about the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right. Any questions? No? All right, we're getting into the last skill of today. This is not a hard skill. Don't try to make it hard. This is Peri-Care. It's a washing skill. We know all of the washing rules already. The hardest part of this is getting over where you're washing. This is going to be psychologically difficult for you, but probably not as much for the patient as you would think. Remember that you are never the first person to do a skill. I want you to remember that. You are never the first person to do a skill on a patient. CNAs do normal. What does normal mean? It's a routine skill on a stable patient that you've been trained to do and told to do by the care plan, right? Well, if the patient needs a new skill done, that means that has changed. That is not normal. So CNAs are never the first person to do a skill. Somebody else has been there and done it before you. Good? Because the patient's probably going to have questions. We can't answer questions, not in our scope of practice. So generally speaking, the first time any skill is done on a patient, it is done by the nurse to answer any questions the patient may have about that skill. Good? So by the time you get there to do Peri-Care on the patient, they already know what's happening. They know what to expect. They know all of the things. So this is routine for them. But the first couple times for you, it's a little uncomfortable. I just want you to have the right mindset for this. Good? Make sense?
This is one skill that is more important than ever, that you talk to the patient, that they know where you're going and what you're doing while you're there. You have to talk to the patient. Otherwise, it's very awkward. Oops, let me go back here. So if you look, we know all of these. There's nothing new here. We know all this. We have to learn this, and you know most of that too. We're going to get to that in a minute. But down here, somebody with your level of experience should be able to do this in 17 minutes or less. Remember, partial bed bath was 19. This is slightly shorter than partial bed bath. Not much. This is going to be done on a mannequin, just like partial bed bath. So this might be one that you'd want to practice in the classroom. That mannequin will be in a bed, and charting is not required for this skill. Page 153 has our care plan at the top, step-by-step instructions, and then your supplies at the bottom. There are a lot of supplies for this. You have to learn them. But in order to do this skill, we have to learn a little bit about why we're doing it. So I've got a little bit of a lecture to give you on incontinence in order to understand why we're doing this. That is because our care plan says the female patient has been incontinent of urine and needs perineal care. For the test, we're going to be demonstrating this on a female mannequin because the risk of infection is very high on females. That's because your urethra, or the tube that goes from your bladder to the outside world, is only about as long as your pinky. So if you bring bacteria here, it's not very hard for them to climb up and into the bladder. So the way we wipe becomes very, very important. Men still have a risk, but not as much of a risk because their urethras are longer. Good? Make sense? Okay. So for the test, we're going to be doing this on a female mannequin. It says the pad under the resident is wet, but the gown and bedding is dry. That's a miracle. It'll never happen in real life. You'll have to be changing lots of stuff. But we're going to take the gift they give us for the test. Now, this is a simulation skill. We're really doing the skill with real water and real soap on the mannequin, but the pad isn't really going to be wet under them. We're going to simulate. Good? All right. Nothing new to learn here. We know to follow the care plan. We know to do our opening. We're definitely going to be wearing gloves for this because we're in body fluids and personal skin areas. You need a barrier to put all your stuff on. Your patient's uncovered and undressed, so we need a privacy blanket. Linen rules are going to apply. Keep your patient in the middle of the bed. Washing rules apply. We'll clean the basin the way we clean everything else, and we're going to do our closing. We know all of this. We don't know this. So this is where we're going to focus our attention for the next few minutes. All right. So before we can learn how to care for an incontinent patient, we actually have to learn what incontinence actually is, and more importantly, what it's not. So this is a normally functioning urinary system. You guys all learned this back in 5th grade. You've got 2 kidneys. Those kidneys filter blood 24 hours a day. Your kidneys are always working, whether you're awake, asleep, walking, sitting, running, whatever you're doing, your kidneys are working. They are filtering blood nonstop. They pull out waste products, and those waste products become urine that drips down tubes. So drip, 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 and it collects in the bladder. Your bladder is nothing more than a Ziploc bag. That's all it is. It's a Ziploc bag. Now, as that bladder fills, you get that sensation that, oh, I think I probably need to go to the bathroom. At the bottom of the bladder is a valve. Now, this valve is what keeps all of that urine in the bladder and allows it to fill, to ring the bell in your brain. It says, I got to go to the bathroom. Without that valve, all of that fluid would just fall out, right? So that valve is what keeps you continent. So when your patient is incontinent, it's the valve that doesn't work. The rest of it does. Your kidneys still filter blood, still produce urine, drip, drip, drip. Those drips still go down into the bladder. But the problem is they don't stay in the bladder because the valve is broken. Good? This is what incontinence is. But if you remember, I said that your kidneys filter blood 24 hours a day. Drip, 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 drip. Well, if that valve is broken, that means that all of those drips are going to come out. If you have a patient who is dry, 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 really, really wet, you do not have an incontinent patient. Incontinent patients are going to be wet all the time, constantly. You're going to get them cleaned up, and as soon as you lay them back down, they're going to leak a little bit because it's the valve that's broken. If you have a patient that's dry, 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 that patient is continent. You're just not getting them up and taking them to the bathroom. That's incompetent staff, not an incontinent patient. Got it? All right. Now, when we're talking about incontinence, it's important to draw the distinction between babies and adults. Adults are not just big babies. It doesn't work that way. Your urine is as acidic as the foods that you eat. So you eat and drink things, your body takes the acid from that food and creates urine with it. Now, babies eat and drink very mild stuff. Breast milk, formula, rice cereal, baby food, right? It's all very mild, not acidic at all. So baby urine is very, what we call pH balanced. You can put a diaper on a baby, put them to bed, wake up the next morning, 8 hours, 10 hours later, whatever, and they still have skin on their little tushes because that urine is not acidic enough to eat through the skin. It's very mild because what they eat is very mild. Adults, almost everything we eat is acidic. Almost everything we drink is acidic. So that means that our urine has a much higher acid content. You leave that acidic urine, that wet whatever, up next to their skin for a long time, and it will eat the skin. That's what acid does. It eats the skin. So we can put a baby to bed all night and they're okay. You can't do the same with an adult. With an adult, you need to clean and change them every 2 hours around the clock to get that acid off of the skin. That means that we're waking them up at 2 a.m. and 4 a.m. and 6 a.m. and 8 a.m. and changing them, cleaning that skin to get the urine off of it before we get them ready for the next 2 hours. Good? Make sense? I want to talk to you about adult briefs. We do not call these diapers. These are adults. We never use baby terms for adults. We call them adult briefs. You'll hear them called depends as well. But there's a problem with these. They are designed to be waterproof, right? We don't want them leaking everywhere. They're designed to be waterproof. But that waterproof is going to hold the moisture right up next to the skin. It's also going to block out light and hold in heat. So now we've got warm, dark, moist. This is the ideal breeding environment for pathogens. And our patients who are incontinent and who are in adult briefs nonstop tend to end up with skin issues, rashes, wounds, skin burns, all kinds of really bad things. So when your patient is up and about, interacting with other people, going to activities and meals, adult briefs are indicated because nobody wants to wet themselves in public, right? This is appropriate. But when they are in bed, there's a better way. Instead of having an adult brief on them, a lot of times we will leave them open to air laying on a pad. That allows light to circulate, allows heat to dissipate, and it spreads the urine out along the pad rather than holding it right up against the skin. Not every patient will be open to air. This is a personal preference. Some patients aren't comfortable with that. That is the nurse's responsibility to figure out who is going to be in an adult brief and who is going to be open to air. Our job is to follow the care plan. Make sense? Okay. So we have a patient who has no undergarments on, who is laying on a pad. That urine is going to spread out, and it helps reduce skin issues and infections. But let's take a moment to think about that pad. Remember I said room temperature always wins? Well, urine is up here in our furnace area where it's being made. So urine, when it comes out, is about 100 or 101 degrees. Yeah, it's very warm. So you get that 100-degree urine to spread out and encounter 75-degree air, and it cools down really quick. So that pad is going to feel cold and wet to your patient. What do you think the first thing they're going to want to do is? Yeah, get a new dry pad under them. So for Peri-Care, that's going to be our first step. When we have a patient who is laying on a wet pad, we're going to change that pad out first to get them comfortable. But we got a wet butt on a clean pad. So once we get them cleaned up, we're going to change that pad again at the end. Clean butt, clean pad. Good? Do you guys remember this that we learned last class? The leaves method. We have a washcloth folded in half and in half again, and I'm going to hold it so it's in a diamond shape in my hand with the free corners at the top. We tuck in the two side corners, and now we have an area to clean with. You're going to clean, fold, gives us a new cleaning area. We're going to clean, we're going to fold, gives us a new cleaning area. We can clean, we can fold, give us a new cleaning area. And then we can even fold that and use the back side as well as a new cleaning area. This is called the leaves method, and we have to use this method when we're cleaning genitals or the anal area, which is what we're doing with this skill. So the first step we're going to take is to change that chucks, and we do that. Clean rolls toward me, dirty rolls away. We already know how to do this. It's just a smaller version of the sheet. And then we're going to wash. So I'm going to hold my washcloth, and I'm going to go right down the center. Now, when I do that, I never want to go back up. This is a one-way trip. So we start at the top, we go right down the middle, move away, and fold that over. I'm going to go down the outside from top to bottom, move away, fold that over. I'm going to go down the other outside, top to bottom, move away, fold over. And then this area between the leg and the groin, this skin fold, this crease, we're going to go down, again, one-way trip, move away, fold over, and then I'm going to go down that side. And I'm going to put that aside. Whatever we wash, we rinse the same way. So I'll get my second washcloth, wring it out really well, no drippy wet washcloths. Using the leaves method, I'm going to clean or rinse down the center, fold it over, down one side, fold it over, down the other side, fold it over, skin fold it over, skin fold. We'll set that aside, and then we'll dry. The big point here is never go back up, because you don't want to take bacteria from the anal area right up to the urethra, where it can invade the bladder and cause a UTI. Okay? One direction only, top to bottom, and move away. This is unfortunately one of the most failed steps, is that people tend to go from top to bottom and then they go back up. We don't do that. One direction only. Okay? So the areas that we're cleaning, we want to clean down the inside middle. And if you can kind of retract a little bit with your top hand and hold open just a little bit to clean down the middle, you can get it a little more effectively. And then outside, outside, skin fold, skin fold. Good? Never move back up. Then we have to clean the butt. So in order to do that, we got to get our patient on their side. So if we're going to turn a patient on their side, we always scoot them toward us first, so that after the turn, they're in the middle of the bed. Correct. So we scoot them toward us, we roll them up on the side, and then we're going to take washcloth number 3, wring it out, put some soap on it, and we're going to wash the buttocks using that same leaves method. So I'm going to go right up the center crease. I'm going to start at the anal opening, go right up that center crease, and that kind of acts like a riverbed, so all the urine's going to be channeled up through that center crease. So we're going to go from anal opening up the center crease, and then I'm going to fold that over. I need a clean area. I'm going to clean one cheek. I'm going to fold that over. I'm going to clean the other cheek. I'm going to fold that over. And then we're going to go once more up that center crease because we know there was a lot of urine there. And then I'm going to set that aside. I'm going to take washcloth number 4 out of the water, wring it out because whatever we wash, we rinse. That's right. Oops, let me go back here. So whatever we wash, we rinse. So I'm going to rinse up the center crease, fold it over, rinse one buttocks, fold it over, rinse the other buttocks, fold it over, and then once more up the center crease because we rinse the same way we washed. Set that aside, and then I'm going to dry. Once I have the back side washed, rinsed, and dried, we're going to change that chucks out one more time. Now we have a clean bottom. We need a clean chucks to put it on. And now they're good to go for another 2 hours. Good? Questions?
Can we go back in with a towel to dry them off? Or-
Yep. Yep. And the same towel that you dried the front with, you can dry the back with. You don't need a separate towel. It's like you getting out of the shower, right? You don't use a separate towel for every body part.
Is there ever a time where we should do the backs of the thighs as well?
It will depend on, yes, your setting and your care plan, yes. But for this purpose, no, just the buttocks is all we need. Usually, in most cases, you are going to be giving a bed bath as well as Peri-Care because this urine doesn't get limited to just this one space. So you'll probably be washing a whole lot more than this. But for the test, this is the area that they're focusing on because they know that if they can see you wash the peri area and the backside, you can wash the back of the thighs. We know you can do that. We don't need to see it. Okay. Good. So basically anything that came into contact with whatever's wet is what we're going to wash. Good. So we know all the steps now. Let's use them to check off our checklist. And this is a long checklist. Super long. A lot of steps here. But we're just going to follow our care plan. We're going to do our opening. We're going to monitor our gloves. We're going to use our barrier to put our supplies on, get our privacy blanket, adhere to linen rules, make sure our patient's always in the middle of the bed, use our washing rules, our basin cleaning rules, and the skill-specific steps, namely, don't go back up. Then we'll do our closing, make sure our environment's clean, and that's how we're going to get 100% on this skill. Remember, this one is just for this patient. Now, this skill, if you go toward the end of the step-by-step instructions, you'll see a whole section on male Peri-Care that you can read, done very similarly. Again, you always want to move away from the urethra and clean what's there. But your skills book does cover male Peri-Care. All right. So we are going to watch the video for this. This video is a little bit longer because this is a little bit more involved skill. Once we're done with that, Jake is going to pass out the review sheets for today, and then we'll sign off of online, and you guys will have probably close to about an hour and 20 minutes of practice time today. Okay.
Hello, Miss Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I need to perform Peri-Care. Is that okay? I'm going to close your curtain, wash my hands, get my supplies. I'll be right back. After washing my hands, I'll get my clean supplies. We're going to place the supplies on an overbed table, and we'll start with a barrier on the table, making sure that the absorbent side is facing up to catch any water spills. This gives us a clean place to put our clean supplies. For this skill, we're going to need 2 chucks. We'll need a towel, 4 washcloths, 1, 2, 3, 4, and a privacy blanket. We'll go to the patient area. And now I'm going to get a basin and soap. We'll place this on the overbed table. And I need a set of gloves. Now I'll go fill the basin. Miss Jones, I'm going to go get some water. I'll be right back. To fill the basin, I'm going to use a paper towel to turn the faucet on because my hands are clean. I'll use my wrist to feel the water temperature. It should feel warm, not hot, not cold, just warm. And we'll fill the basin about 1/4 of the way full. Mrs. Jones, would you like to check the water temperature? It's good? Wonderful. I'm going to set this on the barrier. And this is a privacy blanket. This is going to keep you warm and protect your privacy while we do this skill. I'm just going to stretch it out over your sheet. And then I'll pull the sheet down underneath the privacy blanket. And we're going to pull the sheet down to about your knees. Now, I'm going to prepare my chucks. I'll unfold them, hold them up lengthwise, and I'm going to roll it toward me. Clean rolls toward me. All the way to the end. I'll put this on the barrier and do the same with the second. I'm going to open it up. Hold it up lengthwise with the absorbent side facing me and roll it all the way to the end. Clean rolls toward me. We'll set that on the barrier as well. Now I can put my gloves on. I'm going to place the washcloth in the basin to warm. I'll take one of the chucks that's rolled. I'm going to lay it up next to the patient under the soiled chucks. And Miss Jones, if I can have you scoot toward me, please. And we're going to roll up on your right side so I can change the chucks under you. I'll help you roll. Okay, now that you're on your side, I'm going to take the soiled chucks and roll it in. Clean rolls toward me, dirty rolls away. I want to roll it so that the absorbent side is on the inside and the waterproof side is facing up. I'm only going to touch the waterproof side, and I'm going to tuck it underneath the patient's hip. I'll unroll the clean chucks and tuck it underneath the patient's bottom area, under the dirty. Okay, Miss Jones, come on back. Thank you. And if you can scoot to the middle of the bed. Thank you. I'm going to go around to the other side. Go ahead and scoot toward me. Thank you. And roll up on your left side. 1, 2, 3. And I will remove that chucks, the soiled one, and smooth out the clean. We'll fold this up and we're going to throw this directly into the trash can. Okay, Ms. Jones, can you scoot back to the center of the bed, please? Thank you. I'm going to expose you now. I'll make this as brief as possible. Please let me know if you're uncomfortable in any way. I'm going to roll the gown inside the privacy blanket, and this will expose the peri area. And then I'm going to use a towel over the upper thighs to keep all of that area dry. Now we're ready to clean. I'll take the first washcloth, wring it out, and soap 5 corners. We're going to use the leaves method, meaning the free ends are at the top of the diamond shape. I'll spray the first leaf, fold it over, spray the second leaf, fold it over, spray the third leaf, fold it over, spray the fourth leaf, fold it over, and the back. I'll set that aside. Now I'm going to clean the peri area. I'll hold the washcloth in my hand in a diamond shape, tucking in the 2 side corners, making sure I have control over the leaves and they're at the top so that we can minimize cross-contamination. Okay, Ms. Jones, I'm going to start cleaning you now. I have to hold you open just a little bit, but let me know if it gets uncomfortable. So I'll take the heel of my hand at the top of the peri area, retract slightly, and spread her open a little bit. And I'm going to clean right down the inside middle, top to bottom, one direction only. Once I reach the bottom, we'll move away and fold that leaf over. I'm going to clean the outside peri area, top to bottom. Fold that leaf over. The other side, top to bottom, making sure I don't ever move back up. Fold that leaf over. The fourth leaf will go right down that skin fold, the crease between the thigh and the groin. We'll fold that over, and then we'll clean this skin fold, top to bottom, and we'll set that aside. Whatever we wash, we rinse. So I'll wring out my washcloth using that same leaves method, tucking in the 2 side corners. I'm going to retract the labia and clean top to bottom. Down the center, fold that leaf over. The second leaf will clean the outside of the peri area, top to bottom. And then we're going to fold that leaf over. The third leaf will clean the outside of the peri area on this side, top to bottom. I'll fold that leaf over. The fourth leaf will clean the crease, top to bottom. I'll fold that leaf over, and then we're going to clean this crease, top to bottom. And now we'll dry. Okay, Ms. Jones, I'm just going to unroll your privacy blanket, putting the gown back over your legs, and I'm going to ask you to scoot toward me and roll you on your side so I can clean your backside. 1, 2, 3, and we're going to roll up. 1, 2, 3. We'll expose your backside, and the evaluator will hold the mannequin in place for this process. So now I can clean the backside. I'm going to wring the washcloth out. And this time, we're going to soap 4 leaves. So 1, we'll fold that over. 2, fold that over. 3, fold that over. 4, set the soap aside. I'm going to start at the anal opening and move up the crease. Just like that. We'll fold that leaf over. I'm going to clean 1 buttocks. We're going to fold that leaf over, clean the other buttocks. We'll fold that leaf over, and then once more up the crease. We'll set this washcloth aside. Whatever we wash, we rinse. So I'll wring that washcloth out really well. I'm going to hold it in that leaves shape. I'm going to rinse right up the center crease. Fold that leaf over. We'll rinse 1 buttocks. Fold that leaf over. Rinse the other buttocks. Fold that leaf over, and then once more up the center crease. Now we'll dry those areas. So starting at the anal opening, we'll dry all of those areas. We'll set that aside. Now I'm going to take the new chucks, place it under the one that's on the bed, and we're going to roll this one toward the patient and tuck it under her hip, and unroll the new one and tuck it under the soil. Okay, Ms. Jones, come on back onto your back, please. Thank you, and then scoot to the middle, please. And I'm going to go around and remove that soiled chucks. Go ahead and scoot toward me. And then we're going to roll up on your side, 1, 2, 3. So I'll remove that soiled chucks and smooth out the new one. Come on back onto your back and then scoot to the middle of the bed, please. Thank you. This will be thrown away. Okay, Miss Jones, you're covered. You're in the center of the bed. I'm going to go put your dirty linens away and clean the basin. I'll be right back. These items will go in dirty linen hamper. And I'll clean the basin the same way we clean all basins. We're going to dispose of the water into the sink, rinse the basin, dispose of the rinse water into the sink, set it down, disinfect it per facility policy, use a paper towel to pick it up, paper towel to dry the inside, throw that away, paper towel to dry the outside, throw that away, and one for the drawer. On the way, we'll pick up the soap, place it in the basin, use the paper towel to open the middle drawer, pick up the lotion and put it in the basin, and then store the basin in the drawer. We'll close it with a paper towel and then throw those paper towels away. We'll dispose of the barrier that's on the table, and then remove my gloves. Okay, Ms. Jones, I'm going to pull your privacy blanket up and put your sheet back in place. We'll make sure that the patient is covered and that we roll the privacy blanket up in a ball as we remove it from the patient. I want to adjust the sheet for neatness and appearance. And I'm going to go place this in dirty linen. Okay, Ms. Jones, are you comfortable? Is there anything else I can get for you while I'm here? Would you like a magazine? No? Okay, your environment is clean. Here's your call light. If you need anything at all, just press that red button and somebody will be happy to help you. Your bed is in the low position. I'm going to open your privacy curtain and go wash my hands. We'll return this table to storage before we go, leaving our area clean. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Okay. This is today's worksheet. Those of you who are joining us virtually, you can download these exact same worksheets. Here you go. On flcnatraining.com. So it's FL, like Florida, cnatraining.com. You can download the worksheets. This is a reminder of the practice kit so that you can practice all of the skills that we've gone over in class. And your homework tonight is going to be chapters 8 and 9 before Monday. We've already talked about our homework. Your next steps, you're going to get a wrap-up email, and then this is the review sheet.
I believe we passed them out. If not, they're right up there. You can grab one on your way out. It'd be class. Oh, did you not get one from Monday? Email? All right, Jake will take a look at that. All right. So those of you who have joined us virtually, thank you so much for stopping in. We will see you on Monday. And stay tuned because I'm revamping our main website. So coming soon, hopefully I'll have the beginnings of it available by next week, but coming soon, foryourcna.com/start. And we're going to have a lot of really cool new resources on there for you. So I'll be giving you more information about that next week. So foryourcna.com/start will be a new page on our website to help you navigate all the resources we have a little more effectively and add some new ones in. So hope to see you there. All right, guys, until next time, happy caregiving. Have a great weekend. Do something fun.